threshold tone decay is seen in retrocochlear hearing loss. Now, how is it being elicited? For that, you are giving a 4K Hz tone to the patient continuously for 60 seconds. Okay, and it is given 5 decibel above the threshold tone decay test. For that, you are giving a tone of 4K Hz 5 decibel above the threshold, and it is given for 1 minute. Okay, for 1 minute is being given, and what is being done? We are trying to see if the patient is able to hear for 1 minute. If it is a retrocochlear hearing loss, he won't be able to hear it. Okay, then what you do is you will increment the sound by 5 decibel and try to see if the patient is able to hear for 1 minute. This increase in the intensity is done until the patient is able to hear for 1 minute. If more than 25 decibel such increment is needed, it is indicative of retrocochlear hearing loss. Okay, retrocochlear hearing loss. So that is about threshold tone decay test. So we have now learned about various tests to differentiate between cochlear and retrocochlear hearing loss. What are they? First of all, we learned in speech audiometry. What did we learn? Speech audiometry has got a curvilinear pattern, and you will be able to hear 100% of the speech if you are able to increase the intensity enough. And this 100% of sound won't be heard in case of cochlear and retrocochlear hearing loss. But in retrocochlear, there is another difference is there. That is, when the intensity is further increased, the patient will be hearing even less. Okay, that is happening in retrocochlear hearing loss. So that is what is called as rollover phenomenon. Okay, in cochlear there is no such rollover phenomenon, but the patient won't be able to hear the 100% of the sounds. In conductive deafness, the patient will be able to hear the 100% of the sounds, but at an increased intensity. That is how you differentiate between them in speech discrimination score in speech audiometry. Okay, and it is this rollover phenomenon. It is for retrocochlear hearing loss. It is found in doing the speech audiometry, that is speech discrimination score. When you do a speech discrimination score, if the curve goes up and then comes down, that is initially the patient is able to hear up to 70% of the sounds, and then later on it goes down to about 60 to 50%. If it is going down like that, that is what is meant by rollover phenomenon. Now, what is happening in recruitment? In recruitment, there is abnormal growth of loudness, and that is indicative of the cochlear hearing loss. Okay, in retrocochlear hearing loss, it won't be there. There is no recruitment, and CC will be 80 to 100% in case of cochlear deafness, and in retrocochlear it will be about 0 to 20%. In case of the tone decay test, the cochlear will show no tone decay. In retrocochlear there will be tone decay. Acoustic reflex decay will not be present in case of cochlear, but it is present in case of retrocochlear. Acoustic reflex threshold is decreased in case of this cochlear, whereas in retrocochlear there is no such decrease in acoustic reflex threshold. Okay, so these are the differentiating features between a cochlear and a retrocochlear sensorineural hearing loss. Okay, so these are the things that you have to know how to differentiate between a cochlear and retrocochlear hearing loss. Now coming to the evoked response audiometry. In evoked response audiometry, what is happening? You are giving auditory stimuli, and the electrical response from the auditory pathway is being measured, but it is not exactly what is happening in case of autoacoustic emission. It is not the electrical activity that is being measured here, it is the sound that is being generated by the outer hair cells that is being measured in case of autoacoustic emissions. Normally the outer hair cells have a function of modulating the function of inner hair cells, and that function is actually leading to the production of these sound waves, and these sound waves are picked with the help of microphones, and this was what was discovered by David Kemp. He discovered that living ear has a biomechanism for enhancing auditory energy after it enters the ear, and he was able to record it. And this is not David Kemp, this is Justin Kemp, a South African cricket player. I showed his photo because if you see this picture, sometimes you will be able to remember that autoacoustic emission is same as Kemp waves. Okay, Kemp waves. And these autoacoustic emissions, even though are generated spontaneously, the spontaneous OAE is seen only in 50% of the population. So it is the evoked OAE that is used for measurement, and in the evoked OAE there are two types. One is the transient evoked OAE. Here what you are using is you are giving some clicks. Clicks are a mixture of frequencies, okay, and the response evoked is being measured, okay. And the second one is DPOAE. What is this DPOAE? DPOAE stands for distortion product OAE, okay, distortion product OAE. Here frequency specific tones are being given, okay, two different frequency tones are given and they interact with the OAE generated, and the sound that is hence generated is measured, okay. This is used for high frequency hearing loss detection, okay, 1000 to 4000 hertz, in that range it is discovering. So for high frequency hearing loss detection, when there is a drug induced hearing loss or noise induced hearing loss, can be discovered with the help of distortion product OAE, okay. Now these are the different types of OAE, and what is the use of this OAE? OAE is used for screening for hearing loss, okay, screening for hearing loss in newborn. This is the most important use of OAE. And how are the responses given? It is given as either pass or refer. If it is refer, you will have to repeat it again, and when repeating you have to look for if the axillary canal has some wax or some debris which is interfering it with this autoacoustic emission, or you also have to do a tympanometry to rule out any mid-ear problem. And if it is still refer, you have to go for a definitive measure like auditory brainstem response, okay. So what are the uses of these autoacoustic emissions? First of all, it is used as a screening test of hearing in neonates, okay, and it can also be used for testing hearing in uncooperative or mentally challenged individuals. And if you are having to sedate these patients, it is not a problem, because even after sedation the autoacoustic emissions are being released, and it can be used to distinguish a cochlear from a retrocochlear hearing loss. And you can diagnose retrocochlear pathology, especially auditory neuropathy, where autoacoustic emissions will be present and the ABR will be absent, okay. These are the various uses of autoacoustic emissions. Now if the autoacoustic emission is coming as refer in spite of a normal tympanometry and after removing all the debris and wax from the axillary canal, then you will have to go for a specific test, what is called the BERA. Now this BERA can be done only under general anesthesia, and here what is happening, the various electrical signals in the different areas of the auditory pathway that are being generated are measured, and this is not a simple thing. That is why it is not used for screening purpose, but in children who are born in ICU, that is infants in ICU, like those who are infected with prematurity, who have low Apgar score, hyperbilirubinemia, hypoxia, all these infants will require a BERA, okay, because they are high risk for SNHL. And what is this BERA? It is brainstem evoked response audiometry. Here the various waves that are being generated by the electrical response as the nerve impulse passes through the auditory pathway are being measured, and there are totally 7 waves, but only 5 are being measured. What are these 7 waves? Yes, this is how it looks like. This is wave 1 to 5 which are being measured. And what are they? You know, the E. coli is the code for the auditory pathway, right? 8th nerve, cochlear nucleus, superior auditory complex, lateral meniscus, inferior colliculus, medial geniculate boundary, and the auditory nerve. And here it is 8th nerve, okay, wave 1 is 8th nerve distal part, then you have the 8th nerve proximal part, okay, then you have the cochlear nucleus, then you have the olivary complex, lateral meniscus, and inferior colliculus. Okay, so this is how it is, E. coli. Okay, so the lateral meniscus and inferior colliculus are seen in the wave 5, and this is the biggest wave. This is the wave which you have to look for, especially when you are measuring the interoral difference. Okay, now in brainstem evoked response audiometry, the integrity of the pathway is being checked, and there are waveforms with discrete peaks, and the latency and amplitude of these are used for assessing if there is any abnormality. Now, what are the uses? It can be used as a screening procedure for infants to determine the threshold of hearing in children, and in adults who do not cooperate, because otherwise you could have used a pure tone audiogram. Here hence you will need a BERA, and the site of lesion in retrocochlear pathology can be assessed, and it can also be used for diagnosing brainstem pathology. So what are the things that you look for in a patient who is suspected of having a vestibular schwannoma? Now, you know that in vestibular schwannoma, it is a tumor which is arising in the area of inhalatory meatus. The details of this tumor will be discussed in a separate session. Okay, for now you know that it is a tumor arising from inhalatory meatus. So what will happen? The wave 1 will be present, but wave 2 will be getting delayed, right, because of that tumor, because wave 1 corresponds to the distal part of the cochlear nerve and wave 2 to the proximal part of the cochlear nerve. Okay, so there will be a latency between the wave 1 and wave 5. This latency, interwave latency, is increased, and this wave 5, which is the most prominent wave caused by the lateral meniscus, it is will be delayed. Okay, it will be delayed even if the tumor is compromising the vascularity to the cochlea, which can lead to disappearance of all the waves, wave 1 to wave 4, but still wave 5 will be present. Okay, so you have to look for wave 5 and the latency between the 2 ears, and the interoral latency more than 0.2 millisecond. Okay, here a interwave latency will be more than 4.4 milliseconds. Okay, so this is how you diagnose a case of vestibular schwannoma, and it is the best auditory diagnostic tool. Okay, in case of this vestibular schwannoma, the best tool to diagnose is a gadolinium enhanced MRI. If you are asked about an auditory diagnostic tool, it is BERA. Okay, BERA is used for diagnosing acoustic neuroma. Okay, so these are the interpeak latencies that have to be looked for. Okay, interpeak latency more than 4.4 milliseconds. Okay, and interoral latency, it is actually more than 0.2 is enough, and the wave 5 may be absent if it is a large tumor. Okay, that is also diagnostic of a vestibular schwannoma. What else can you look for? You can monitor the vestibular cochlear nerve during its surgery, okay, and you can also look for the maturity of CNS, and it is also used for the objective identification of brain death and for assessing prognosis in a comatose patient. Okay, so that's about BERA, and instead of BERA you will have to do an auditory steady stem response, okay, if the hearing loss is above 80 decibel. Okay, in that case you will need to look for auditory steady stem response, okay, or ASSR. And another question that was asked is BERA is most accurate. This question, it is not at all confusing, okay, it is actually straightforward question, because the CNS maturity takes place very slowly, and it is only by 34 weeks the CNS maturity becomes complete. So BERA will be most accurate at 34 weeks. So the answer is 34 weeks. Now coming to another investigation which is done for identification of cochlear hearing loss, that is electrocochleography. Here the different waves that are being generated in the cochlea are being assessed. Okay, how? By using an electrode that is pushed into the promontory, and it has to be done in GA in children, and in adults it can be done under local anesthesia. What are the three potentials that are being generated? You have the cochlear microphonic in the outer ear cell, summating potential which corresponds to the cochlear activity, and action potential which is the firing of the auditory nerve. Okay, and it occurs within first 1.5 to 2 millisecond. Okay, so that's about the electrocochleography. It can be done in a non-invasive manner, but the invasive electrocochleography is more accurate. Okay, so what are the things that you look for in the electrocochleography? You are looking for the SP by AP ratio, and this SP by AP ratio should be more than 30%. Okay, more than 30%. That is diagnostic of Meniere's disease. Okay, why is it so? In Meniere's disease, the summating potential will occur normally, but the action potential will be delayed because of the dysynchronous response of the hair cells. Okay, so SP by AP more than 30% is diagnostic of Meniere's disease. So that is what is looked for mainly in this electrocochleography, and of course it can be used for auditory dyssynchrony and in pre-implant assessment to assess the cochlear function. Okay, so these are the things that you have to learn in case of electrocochleography. So what are the things that we learned today? We have learned about the various investigations to identify between a cochlear and retrocochlear hearing loss. This has to be done when you find that the deafness is of sensory neural type. If it is a conductive deafness, what has to be done? You have to look for what is the middle ear pathology, and for that you have to do an impedance audiometry, and this impedance audiometry consists of tympanometry as well as acoustic reflex. And apart from the various investigations to differentiate between cochlear and retrocochlear hearing loss, like the recruitment, the ABLB test, the SISI short increment sensitivity index, the tone decay test, you also have to know about the autoacoustic emission and BERA, which are used for screening for hearing loss in children, and also you have to know about the last one that you learn. What is that? It is the electrocochleography. Okay, now with that the assessment of hearing part is complete. In the next class you will be learning about the diseases of middle ear, and then you will be going to the complications of the chronic otitis media in the coming sessions. Okay, for now, goodbye.